So our next presentation is virtually, and the presenter is going to be live after. Statin use reduces mortality in patients who develop major complications after TCAR by Dr. Chang and colleagues.
Good evening, everyone. First of all, I would like to thank the program committee for the privilege of this presentation. I have nothing to disclose. Carotid artery disease is one of the leading causes of ischemic strokes in the US. Previous literature have shown that carotid endarterectomy is associated with improved outcomes in these patients, and it is a gold standard for carotid revascularization in these high-risk patient population. However, TCAR is emerging as a new novel therapy for revascularization of these patients. It has benefits of being minimally invasive with a small wound, and it uses the flow reversal technique to prevent any embolic strokes. Previous studies have shown that pre-operative or perioperative use of statins was associated with lower rates of strokes and mortality in the patients who were going carotid endarterectomies. So the patients who underwent carotid intervention, one of the most dreadful complications was stroke, a major cardiac complications, and the mortality because of those events. The use of statins have not been studied well in the patients who are going a TCAR. So the aim of our study was to assess the impact of perioperative or preoperative statin use over failure to rescue among patients undergoing TCAR. We hypothesized that the preoperative statin use decreases the rates of failure to rescue among patients undergoing TCAR. We performed an 8-year analysis of the Vascular Quality Initiative program database, and we studied the carotid artery stenting registry. We included all the adult patients who underwent a TCAR. Based on the preoperative statin use, the patients were divided into two groups, a statin group and a no statin group. The patients in the statin group were those who were on statins for at least 30 days preoperatively. Our outcome measure was failure to rescue, which was defined as a death after major postoperative complications, including stroke or a major adverse cardiac event, which included a myocardial infarction, a congestive cardiac failure, or an arrhythmia. We performed multivariate regression analysis to control for the confounding variables. We included a total of 16,000 patients in our analysis. Out of that, 10% of the patients were on statin pre-operatively, while 90% of the patients were included in the no statin group. This table represents the patient baseline patient demographics, including age, gender, race, as well as comorbidities. There was no difference between the two groups in terms of age or ethnicity or race. However, the patients who were in the statin group were more likely to be male compared to the patients in the no statin group. On analysis of the comorbidities, we found that the patients in the statin group were more likely to have comorbidities, including coronary artery disease, hypertension, diabetic, and they were more likely to be smoker. There was no difference between the two groups in terms of chronic kidney disease. On analysis of the ipsilateral strokes, the patients in the statin group were more likely to have an ipsilateral stroke compared to the patients in no statin group. This table represents the preoperative use of medications, including aspirin, Plavix, beta blocker, anticoagulation, as well as the procedural details. You can see the patients in the statin group were more likely to be on aspirin, Plavix, as well as on beta blockers. There was no difference between the two groups in terms of the use of preoperative anticoagulation. On analysis of the procedural details, there was no difference between the two groups. On average, 90% of the patients in both groups underwent an elective procedure. Around 28% of the patients received a general anesthesia. A mean number of stent deployed was 1. The mean operative time was around 1 hour, and the mean contrast used was around 25 cc's during one procedure. 99.5% of the patients achieved technical success during the procedure. This table represents the post-operative outcomes of both groups. On analysis of the post-operative outcomes, we did not find any difference between the two groups in terms of stroke or any major cardiac adverse events. There was no difference between the two groups in terms of mortality. However, the patients in the no statin group had higher mortality, around 0.7% compared to 0.4%. However, the numbers were too low to show any statistical significance. This table over here only present the patients who died after a stroke or a major adverse cardiac event. You can see the mortality in this subgroup of the patients who were not on any statin preoperatively had higher mortality, around 11.5%, compared to around 6% in patients who were on statin preoperatively. Although there was no statistically significant difference, most likely because of low numbers, but you can see there was a trend towards the higher mortality in the no statin group. Then we performed a multivariate regression analysis to control for confounding variables, including comorbidities and other confounding variables. We found that preoperative statin use was independently associated with lower odds of death after any major adverse cardiac events or stroke. The odds ratio was 0.38 and it was statistically significant, which signifies that preoperative statin use was associated with 62% decrease in mortality after a major adverse cardiac event or a stroke. This is a diagram which just shows our multivariate regression analysis, and you can see, again, statin was independently associated with lower odds of mortality or lower odds of FTR after a major cardiac event or a stroke. So in the light of our study, we conclude that statin use was associated with a significant reduction in failure to rescue among patients who developed major post-operative complications after TCAR. In addition to appropriate patient selection and structured perioperative management, adherence to statin therapy may improve patients' outcomes. In the end, I would like to thank Dr. Maldonado from NYU and Dr. Chang for the opportunity for me to get involved in this project, and I would be happy to take your questions.
The paper's open for discussion.
I had a quick question. Thanks for a nice presentation. How do you account for 90% of patients not being on a statin? This is a relatively new technique, relatively newly captured in the VQI. The VQI has been around for over a decade. I find it, and it's a procedure done only by vascular surgeons. And I'm curious how you could explain only 10% statin use in 15,000 patients.
So one of the specific indication, or you can say the variables we used, was the patients who were taking statin for more than 30 days, and only the patients who were compliant were included in the statin group. So I think it was, when I ran the analysis, I was pretty surprised too, because most of these patients have multiple comorbidities. They are at risk of atherosclerotic disease, but interestingly, they were not on statin. So it might be because they were not compliant, and that's why they were not included in the statin group.
Hey, Joseph Tingen, Greenville, South Carolina. Yeah, the 90% is just shocking. In our institution, dual antiplatelet therapy statin use compliance is mandatory for us to do a TCAR. I thought that was what everyone was doing, but if that's not, please let us know. It looked like the study also had less than 80% aspirin use, less than 80% Plavix use, and I mean, that for us is just, I mean, we would never do that in our institution. Is that the norm around the country, or is this VQI data just kind of?
Yeah, so most of the patients here at our institution, the patients who have carotid artery disease, all the patients are dual antiplatelet therapy and statin. So I'm not sure what was the treatment guidelines at other institutions in terms of the perioperative or preoperative risk stratification and in terms of their aspirin, Plavix, and statin use.
Okay, thank you.